So, good afternoon and welcome to our webinar on orthostatic hypotension in Parkinson's disease, multiple system atrophy, and Lewy body dementia. The webinar today is hosted by the Multiple System Atrophy Center of Excellence at Stanford, Stanford Movement Disorders Center, and Brain Support Network. My name is Candy Welch, and I'll be moderating today's talk with Dr. Mitch Miglis. Dr. Miglis is a clinical associate professor in the Department of Neurology and Neurological Sciences at Stanford. I'm currently on the BSN board and serve as a leader of our local MSA support group in the San Francisco Bay Area. I cared for my husband, Bob, who passed away in 2008. His MSA diagnosis was confirmed following his brain donation. As I said before, we'll be recording today's event and we'll be uploading it to the BSN YouTube channel. So we hope you'll be able to pass the information on to others that might be interested. Also, it will save you from taking frantic notes during the presentation. Brain Support Network will also be posting a summary of today's information on our website, hopefully by the end of the week. And also at the end of the webinar, we'll have a resources slide that will be visible on this webinar and on the website as well. After Dr. Miglis concludes, we'll hold a question and answer session. Throughout the presentation, we hope that you will submit your questions using the Q&A and the chat button that you'll see on your screen. We're looking forward to those questions, and we'll definitely try to answer as many of those as possible. So now I'm pleased to turn things over to Dr. Miglis. Go ahead.
Okay, thank you, Candy and Robin, for inviting me again. Let me just share my screen. Okay.
There we go.
All right, coming through? Okay, good. All right, so hope this all goes smoothly. I have my two young kids upstairs entertaining themselves right now. So hopefully if I have to deal with any crises, I'll just mute myself or step off camera for a moment, but hopefully we can get through the hour. Okay, so I'm going to be talking about a really common condition in Parkinson's disease, and also, of course, in MSA and also Lewy body dementia, all the Parkinsonian conditions, which is orthostatic hypotension. And orthostatic hypotension is just a medical term for the blood pressure dropping more than it should when we stand or when we're upright. Normally, when we get up from a laying or sitting position, there's a lot of blood that gets redistributed into the lower extremity, into the legs. A lot of the blood is in the stomach area, in these blood vessels around the stomach and the gastrointestinal area. And then a lot of that just gets dumped into the lower extremities. But there's systems in place in our brain that can sense that drop in pressure, and then they will send a signal to the blood vessels to squeeze down. And so up to a liter of blood can be redistributed in this way. And we have this very complex neurological reflex circuit that can sense that and then get that blood pressure up, get that blood back up to our brain so we don't faint. Now, in MSA and Parkinson's disease and these conditions, there's a problem with that signaling due to various reasons. One of the factors is the deposition of the protein in these parts of the brain and in the nerves themselves that don't allow the nerves to fire like they should. So that signal can't get down to the blood vessels, to the veins in your legs to squeeze. And so in that case, if the blood pressure drops and it drops below this certain threshold, that's when we diagnose this condition called orthostatic hypotension, or we abbreviate it OH. So the magic number here, what we would consider abnormal, is more than 20 points, top number. You can use the bottom number as well, but the top number is really what I would focus on, because that number is more correlated with symptoms, with how people feel and how, blood flow to the brain. So if the top number blood pressure drops more than 20 points, and it's not just within the first minute, it also has to be sustained across several minutes. If that number drops more than 20 points and it stays low, then that's abnormal, and then we call that orthostatic hypotension. Typically, how we will measure this and how you can measure it at home is to do a first measurement while you're laying flat, because that's when you're going to get the highest blood pressure, and then stand up and stand in place for at least 3 minutes. What you can do is check the blood pressure immediately on standing and then check it again at 3 minutes of standing. If the blood pressure at 3 minutes is 20 points lower than it was when you're laying flat, then that's abnormal. And some patients, it's very severe. It can drop 100 points or more. So there are many causes of orthostatic hypotension. It's not only Parkinson's disease and MSA. There's a lot of other medical conditions which can cause this. It's very common as we just get older in general. I mean, over the age of 65, by some estimates, mild orthostatic hypotension can be seen in over 20% of the general population. We lose muscle mass as we get older, so the muscles help pump the blood to our brain. So more of the blood can be in the legs when we stand. We get varicose veins. The veins get a little looser. They don't squeeze as well. We may be on more medications as we get older, especially medications to lower blood pressure. So a common story that we'll see when we talk to patients is they've had high blood pressure, especially men, for a good portion of their life. They're on several medications to lower blood pressure. Then they start fainting. We diagnose this condition. And then the first step is to, stop or reduce the doses of those medications. So a lot of medications do lower blood pressure. So that's always a really common cause of orthostatic hypotension. Heart failure, if the heart is not pumping like it should, can cause it. Adrenal insufficiency, which is pretty rare, but if the adrenal glands don't release the chemicals like they should, that can cause it. And of course, if someone is severely dehydrated or if they have anemia, that can also cause it. So again, it's really common. 5% over the age, this should be greater than 50. 5% of the population over the age of 50 can have this, and it could be, even more than 20% over the age of 65. And so it increases with age, and it gets, can become more common and more severe as we do get older. So the other point to mention is that this diagnosis, orthostatic hypotension, it's not always related to symptoms, because the brain is very good at conserving energy and conserving blood flow to itself. As neurologists, we always say the brain is the most important organ. It controls all the other organs in the body. So it kind of preferentially preserves blood flow to itself. And even though the blood pressure that we're measuring in the arm may be dropping by 100 points, that may not be the blood pressure in the brain itself that's being perfused. So not everyone that has chronic orthostatic hypotension even may have symptoms, or they may not recognize the symptoms. So diagnosing this is based on the blood pressure drop itself, and it has no sort of correlation with symptoms that someone would experience. So that's really important when deciding when to treat this. If there are no symptoms, we don't usually treat it. We don't treat the number, we want to treat the symptoms. The caveat, and I think we'll get into this, is that the symptoms can be a little bit difficult to recognize. They might be a little vague. It might not be lightheadedness, but it can be other vague things like fatigue. It can also be related to falls. So falls are common for other reasons in these diseases. So if someone's falling frequently and their blood pressure is low, that might be a reason to treat it. But it's not always just specifically because the blood pressure is low. That's not a reason in itself to treat orthostatic hypotension. So again, can be symptomatic or asymptomatic. So, what are the typical symptoms? Of course, lightheadedness, dizziness. Dizziness itself is really tricky. A lot of people, especially as we get older, can develop vertigo or inner ear problems. So that type of dizziness should be more of like a movement or spinning sensation, and not necessarily related to standing or being upright, versus orthostatic hypotension related lightheadedness is more correlated with being upright, but also kind of more of a sense of wooziness or feeling like someone's about to faint. You can Patients can also get, dimming of vision, blackout of vision. There can be more shortness of breath. Coat hanger pain is pretty common, where you get the sort of cramping in the shoulder muscles because of the decreased blood flow to those large muscles in the neck and the shoulders. Of course, fainting is the end result of low blood pressure to the brain. So that's an extreme example of the result of OH. Other symptoms can be trouble thinking or fatigue. Those are pretty hard to tease out, but if there's really an association with being up and about, and those symptoms get a lot better when someone sits or lays flat, then it's important to look at the blood pressure and to see if it's related to low blood pressure. So sometimes we do tilt table tests to diagnose this. I will say it's not necessary to do a tilt test to diagnose OH. But on a tilt test where we put a little monitor on the finger and we measure the blood pressure continuously on a screen, we can see these kind of second to second changes. And when someone's laying flat, we might see a normal blood pressure. And when they're upright, we see it drop very quickly. They get dizzy, and then we bring them back down, the pressure goes up. The graph on the top is just showing blood flow in the brain. This can be measured. It's not commonly measured, but can be done in research where we put a little probe on the head that measures blood flow. And what this is meant to show is that when the blood pressure drops peripherally, and we see this on the tilt test, the blood flow in the brain doesn't drop that much. It's still pretty good. So this is just meant to emphasize that the brain does something called cerebral autoregulation. It preserves that blood flow to the brain, which is why a lot of people with this chronic severe orthostatic hypotension don't faint all the time, because the brain is very smart at kind of adapting to that and then shunting the blood to itself and at the expense of other kind of tissues in the body. So, kind of discussed a little about other causes of orthostatic hypotension, medications, anemia, that sort of thing. We call that non-neurogenic. It's not a neurological cause. Versus orthostatic hypotension caused by Parkinson's disease or MSA, that's neurogenic. It's neurological. It's due to breakdown of the brain, structures in the brain, and the nerves. The first thing to rule out, even in Parkinson's disease and MSA, is non-neurogenic causes. So the most common cause is medication. So we really want to go through the medication list. If you're taking antihypertensives, we usually stop those. Tricyclic antidepressants can also do it. Sildenafil, Viagra, these are vasodilators. This can do it. So we go through the medication list and just make sure there's no other medications that can be contributing. Levodopa is commonly, drops blood pressure as well. Sleep aids like trazodone or mirtazapine also drop blood pressure. So there's a lot of medications that can contribute. So that's the first step. The second would be look for anemia. Make sure that heart failure is not contributing. Make sure patients are staying well hydrated. But once those are ruled out in someone that has a Parkinson's related neurodegenerative disorder, it's most likely related to that disorder. It's most likely neurogenic because it's extremely common. In Parkinson's disease, probably about 50% of patients have this. In MSA, it's closer to 75%. And the reason this happens is there are nerves that will release a chemical called norepinephrine, these autonomic nerves that line the blood vessels. So the brain kind of senses that signal, the blood pressure is dropping. It stimulates this impulse that goes down, ends up in these nerves, and stimulates secretion of this chemical norepinephrine, which will bind to receptors on the veins in the blood vessels and it will cause them to constrict. In Parkinson's and MSA, these nerves degenerate because of deposition of alpha-synuclein, the pathological protein in the nerves, but also upstream in the brain centers that are like signaling the release of the signaling, those get affected as well. So, the end result is the nerves can't release this chemical and the blood vessels can't squeeze down. So yeah, these are the estimates in Parkinson's disease, and MSA, it's even higher, like I mentioned. Lewy body dementia, it's probably also close to 75% or so. And it's important to recognize this because it's treatable, but also we know that patients with NOH have more falls, and so they have greater chance of having complications of that. There's greater risk of hospitalization and earlier mortality if it's not treated. And so it really contributes to a lot of disability and overall health-related cost, and not even considering symptoms. The health-related cost is about 2.5 times higher in patients that have orthostatic hypotension compared to those that don't. So again, it's important to recognize it, to treat it early, because we can help prevent some of those serious complications like falls. And these points are also more in patients where they haven't been diagnosed with Parkinson's or MSA yet, because orthostatic hypotension can be a very, very early feature of these conditions. It can be present for years or decades before the sort of hallmark symptoms of Parkinson's and MSA. So the other point is it's an early kind of disease feature for some people, and it's important for doctors to recognize that so they can treat it, but also be aware that there might be a risk of neurodegenerative disorders down the line. So when to suspect it? Of course, if there's any unexplained fainting or frequent falls, if there's those typical symptoms of lightheadedness, but also if there's like the more vague symptoms of fatigue or neck cramping when standing, or even confusion when standing. Of course, if you have Parkinson's disease, MSA, or Lewy body dementia, there's a very low threshold for looking for this, and especially if you're on any type of medication that can lower blood pressure. Okay, so the testing we do, the first line testing, usually check, blood count, look for anemia, make sure electrolytes are okay, check thyroid levels, check B12 levels. That's usually been done by primary care. The other thing you can look at, and this is a little bit academic, but it can be important if really you're trying to distinguish neurogenic versus non-neurogenic, is how much the heart rate goes up. In someone who has a non-neurogenic cause of orthostatic hypotension, if someone's lost a lot of blood and their blood pressure is very low, their heart rate's going to be really, really high. If the younger person that's otherwise healthy is very dehydrated, their pressure is low, their heart rate's going to be really high. But in a patient with MSA, if they stand up and their blood pressure drops, into the 90s or lower, usually you don't see an increase in heart rate. And that's because those nerves that sort of signal the heart to increase the rate, those have also degenerated. So for every 20 points the blood pressure drops, we should see an increase in heart rate by 10 beats or more. And it's not something that we always calculate, but it's something we do look at, on testing. If there's a huge drop in blood pressure, but the heart rate only goes up 5 points or so, it's most likely a neurogenic cause. Hopefully that makes sense, because the nerves that control heart rate are similar to the nerves that control blood pressure, and they're both affected by the neurological process. Okay, another point to emphasize is that in these disorders, not only is there a problem with the blood pressure staying up when people are upright, but also a problem with the blood pressure staying down when they're flat. Because those brain centers, they regulate not only high pressure, but not only regulate low pressure, but also high pressure. They're designed to keep the blood pressure in our bodies pretty even. And if they're not working, they can't really bring the blood pressure down when it's too high. and it's high when we lay flat. So what'll happen is when patients lie flat, the blood pressure goes up. Normally that part of the brain will dilate our blood vessels, bring the blood pressure down, so so we're not at risk of high blood pressure related complications. But in Parkinson's and MSA, people will have what we call supine hypertension. When they lay flat, pressure will be really high, and then they stand up, it'll drop really low. And that's because of that neurodegeneration of those baroreceptor sort of areas in the brain. And then when they're sleeping overnight, blood pressure can be quite high, which is not good for the kidneys or the heart over time. And that's something that sometimes we'll treat. And it's not a bad idea sometimes to get a 24-hour blood pressure monitor just to see how high the blood pressure goes at night. This is something that is pretty readily available. You just wear an arm cuff that will go off every hour or so throughout a 24-hour period, and it'll give you this 24-hour graph. So supine hypertension can be just as important as orthostatic hypotension, in these conditions. Okay, so how to manage it, and this next few slides probably 15 minutes or so, so you should have plenty of time for questions. But the first point is, in managing neurogenic OH, we want to treat symptoms and want to improve quality of life, but the goal is not to normalize the blood pressure. That's not possible. We cannot fix the problem, but usually we can improve the symptoms to get patients, a better quality of life, and that's the goal. So the point is not to focus on the numbers, but to try to get the numbers as good as we can, really focus on the symptoms. And if you don't have symptoms, then we don't treat it unless you're falling. And the falling is not thought to be related to the underlying disease. Okay, so the first treatment is non-medication. The first thing to try and do, if you're able to do this, is to elevate the head of the bed. This will not only lower the blood pressure when you're flat because of that supine hypertension, but it'll also this is not really intuitive, but it'll also keep the pressure from dropping so much the next morning. Because what happens when we're laying flat, if you have supine hypertension, is that high blood pressure kind of pushes more of the fluid out of the blood vessels and into the surrounding spaces around the blood vessels. So it's kind of a pressure that pushes fluid out, and some of that fluid will get filtered like by your kidneys, and then you'll end up urinating more in the morning. So your pressure will be lower when you wake up and you're standing in the morning. So if we can keep the pressure lower at night, there won't be as much of a drop in the morning. The problem is that it can be uncomfortable to sleep at 30 degrees. You can try a wedge pillow first, but those are not the most comfortable. So what a lot of patients do is they buy an adjustable bed, an electric adjustable mattress, and they can adjust to their comfort. You can also adjust the legs the legs as well, and kind of find a more comfortable angle. But that will definitely help, the highs and the lows overnight. Compression garments, word on those. I don't usually recommend the prescription grade compression. They're very difficult to put on and take off, and they really don't help that much more than just over-the-counter ones. So the first thing you can try is knee-high athletic socks, just over-the-counter athletic socks, especially when exercising. A waist-high binder or a waist-high tights, like for women, can be more effective than the knee-high socks. And then the most effective is going to be an abdominal binder, which is like a Velcro binder that you can buy for low back pain. You put it around your stomach, and it just kind of keeps a lot of that blood that's in the stomach area from dropping down into the legs. But it's not the most comfortable to wear. So you can start with knee-high socks. You can try stockings that go up to the waist, or you can try an abdominal binder, but I really wouldn't bother with the prescription grade compression garments. Fluid and salt is the next step. So we want to try and get at least 2 liters of water a day. You know, that's really hard, especially, you know, if you have a lot of urinary issues, frequent urination, but 64 ounces of water is the goal. The other point with water is that it can be used as a treatment. You should kind of try to consume water gradually throughout the day to keep your hydration up, but also if you're feeling really lightheaded, you can drink water quickly to boost the blood pressure immediately at that moment. So we call this water bolusing. You have to drink, you know, maybe 250 to 500 milliliters. It has to be just water, no electrolytes. And if it's colder, it's going to be more effective. But if you know, say if you drank sort of a large coffee mug, you know, maybe half of that, if it's cold water, drink that quickly, it can boost blood pressure by 20, 30 points. And it can stay elevated for, you know, maybe an hour or so. So that's an important point. You know, a lot of people don't know that. We can use this almost like a medication, water bolusing. If you're able to drink quickly, this can be helpful. And for salt, 1 to 2 teaspoons, that's the general rule. We want to have salt with the water because the salt helps you absorb the water and keep it in your system. But no salt when you do the bolusing, only when you're kind of, you know, salt is just to be added to your food throughout the day. If you're going to do the water bolusing, you don't want to have any kind of electrolyte or salt solution with that. And then physical conditioning, very important. We want to try and strengthen the muscles in the legs. The muscles pump all the blood. So you want to try to keep your conditioning as much as you can. And it's difficult to do the exercises if you have orthostatic hypotension. So you're going to find it much easier to do things where you're sitting or recumbent, like a bicycle or a rowing machine or aquatic-based activities. And really, you want to avoid anything on a treadmill for obvious reasons. I've, you know, had a few patients who have fainted on a treadmill, so we don't want to do that. Running, and it's just going to be very difficult. So a lot of patients do maybe recumbent bike, rowing machine, or swimming or water aerobics. So here are a few examples of the head of the bed elevation. So this is what was recommended back, you know, I think this is from the 1930s. You have to raise the whole bed up like this. But now we can have these adjustable beds that are much more comfortable. So a lot of patients do that. There can be split beds, so you don't, you know, your bed partner doesn't have to have the same angle. These can be separated for if you have other sleep-related issues, RBD or whatnot. So those can be a very, very good option. This is illustrating that when patients with orthostatic hypotension exercise, their blood pressure actually drops even more. Whereas if someone who doesn't have this condition exercises, the blood pressure goes up. So it's just something to be aware of. You know, you're at greater risk of fainting when you're exercising, when you're upright, if you have orthostatic hypotension. Usually this is not a problem if you're doing those other exercises I mentioned, but you really want to be careful with upright exercise. And this is just pointing out that if you're exercising in a pool, you know, the pressure of the water increases the pressure in our blood vessels, and it squeezes the hydrostatic pressure squeezes those vessels a little bit, so it keeps the blood pressure from dropping as much. If you're in waist high water, your overall blood pressure increases by about five points. So it's a much safer way to exercise if you have access to a pool. These are counter maneuvers. If you feel like you're going to faint, the best thing to do is to sit down or lay down. If you lay down and get your legs up, that's the most effective thing. If you can't sit down, you can do some of these things, like crossing your legs or squeezing your leg muscles, squatting. I mean, I've heard many stories from many patients of having to squat suddenly. A lot of people pretend like they're looking for something in the store to squat down. I mean, what that's doing is just compressing a lot of those leg muscles. You're getting your head closer to the ground, and you're squeezing those leg muscles that pump the blood up to your brain. Okay, so what if we try the non-medication treatments first, and those don't work? What about medications? So these are the common medications that we can use. So I'm going to say the first medication that we usually try is midodrine. And I'll get into the specifics of, the doses and all this, but midodrine basically is a medication that stimulates the receptor on the blood vessels directly and causes them to constrict. The problem with midodrine is it doesn't stimulate the receptors just on the blood vessels. These receptors are in other parts of the body, including the bladder, which is a common problem with midodrine is people can have bladder spasm. It can make the urinary retention worse. It can contribute to more UTIs. It's not super common, but it can be an issue. And the other problem is there's these receptors are in the muscles in the the hair fibers in the skin. So a common side effect of midodrine is it can cause a goosebump feeling or itchiness in the skin, especially the scalp. And that can be really annoying and some people can't take it because of that. But midodrine is really good because it's shorter acting. So because a lot of our patients have that supine hypertension, a longer acting medication is not great. So midodrine is lasts about 2 to 3 hours at a time. So it's usually out of the system by the time they go to bed. It can also be really good to take, as needed doses of, like before people exercise, because it will kick in within 30 minutes. Fludrocortisone is another common one. This is a really long-acting drug. So, if there's severe supine hypertension, it's not a great option. But what fludrocortisone does is act on the kidneys to help retain more salt. So it kind of increases the baseline blood pressure, whereas midodrine squeezes the vessels and sort of increases the peaks throughout the day. So we have a fair number of patients that take both, with more severe disease. The third drug we usually think of is droxidopa. This is third line because it's usually more expensive, although it's gotten cheaper now that it's generic. It's, in my opinion, probably the best drug for this condition because it's a more directly acting medication. It's more of a pure drug than midodrine or fludrocortisone. Droxidopa is converted to norepinephrine, which is that chemical that I showed you before that is not released like it should be in neurogenic orthostatic hypotension. This drug is converted to norepinephrine, and then the norepinephrine acts on those receptors on the blood vessels. So it doesn't have these off-target effects in the bladder and other places in the body like midodrine does. And it's very similar in terms of the duration of action, very similar to midodrine. It's more short acting, so it's usually given 2 to 3 times a day. And then finally, pyridostigmine. It's not a common one, but it's one we use fairly often because it's pretty well tolerated. Doesn't have a lot of side effects. Pyridostigmine increases a chemical called acetylcholine, which will then kind of go down here and stimulate in these other nerves the release of the norepinephrine, which will then cause the constriction of the blood vessels. So those are kind of the common 4 drugs we use. And then there's kind of more off-label ones that we'll use if those don't work. So just kind of going through them individually. Midodrine, this is usually the first thing to try. This has been around for a long time, was approved in 1996. I think the important points to make here is that it kicks in 30 minutes to 1 hour after you take it, and it lasts around 3 hours. Side effects are supine hypertension. All these drugs have that side effect. Goosebumps, and then urinary retention. But it's a good drug, and a lot of people will just need this, and this works really well, and they won't need anything else. It's usually given 3 times a day, but you can take it once or twice a day. The important point, and this is important to make this point because even a lot of doctors don't emphasize this to their patients, that you don't want to take these medications 3 hours before bedtime. So your last dose should be at least 3 hours before you go to bed, because you just don't want to take something and just lay flat when your pressure is going to go up, right? So you want to take this when you're active and you're up and about, not when you're going to sleep. Then droxidopa, again, this is, a lot of complicated chemistry stuff here. The point is that it's really similar to midodrine. It just has less side effects. It's probably a little more effective, but the dosing and the duration of the action is almost identical. So it's usually given 2 to 3 times a day, just like midodrine, typically morning, like lunchtime, and late afternoon. Okay, what else to say? Fludrocortisone. This is only in the morning because it's really long acting. This stays in the body for, more than 24 hours. So it's not great if you have really severe supine hypertension. It can also cause swelling because of the fluid retention. So people can get swelling in their ankles. It's not something you should use if you have any heart failure or major kidney disease. But it can be quite effective, and it's not like an extremely dangerous drug. It's just probably has a little bit more complications than midodrine, but something that we do use a lot. It's just not something that I would use first line. And then pyridostigmine, just the important points here are the side effects. They're usually GI related, because it also speeds up the movement of the stomach and the gut, which can be good for some patients that have more delayed emptying, like gastroparesis. That can be a good side effect. But if people have diarrhea, it's going to make that worse, and it can sometimes cause cramping. But they're usually pretty mild side effects, and this is a really safe drug. Okay, the final drug I'll mention, and then I'm done, is that atomoxetine. So atomoxetine, it increases that norepinephrine in the nerve area. So it sort of creates more norepinephrine for the receptors to bind to. It's typically used for ADHD, so it is a stimulant at higher doses, like 20, 40, 60 milligrams. But for orthostatic hypotension, we use a much lower dose of 18 milligrams. And the side effects can be headache or decreased appetite or insomnia. But usually it's also well tolerated. There's a similar medication called ampreloxetine, and this is the only drug currently in clinical trials for orthostatic hypotension. Some of you may have heard of this drug. It's made by a company called Theravance, and they're enrolling or finishing enrollment now for this trial, which is only targeting MSA patients. But atomoxetine is a generic, like very similar drug. So I will use this in patients that have failed those other 4 that I showed you. And it's hard to predict who's going to respond to this, but some people have felt like this is, the only one that's worked for them. I've heard that from actually some other patient sessions talks that I've given like this. So it's definitely one to, keep on the radar. If the other medications aren't working well for you, you may want to try atomoxetine. And it also, because it has a little bit of stimulant effect, it can also help some of the brain fog or fatigue. And, I think it's generally a safe medication. So, in conclusion, we should all be aware of orthostatic hypotension. It's just so common in these conditions. The symptoms may not always be so straightforward. It's not just lightheadedness. You really want to pay attention to all of your symptoms and kind of see if you can tell which ones are much worse when you're standing and get better when you sit down or lay down. And if you're seeing that there is a trend there, you should do some blood pressure measurements at home. First do the measurement laying flat for a few minutes, and then stand in place for at least 3 minutes, and check the pressure right when you stand, and then again after 3 minutes. If the top number is more than 20 points lower than when you started, then that's not normal. So you should track that. I usually tell patients do a log, measure at least once a day for a week, and then bring that to your doctor. And any doctor should be able to know if it's normal or not. If you do have orthostatic hypotension, you want to try head to bed elevation, compression garments, fluid, salt, and exercise. And if that doesn't work, that's when we think about medication. Most patients with OH that have PD or MSA or DLB, they will require medication. Most patients that do require medication will have a positive response from them. It can be a bit of a process to find the right med or the right dose for each individual patient, but I'd say most patients do have a pretty significant improvement in quality of life once we can find that right dose. But it's not going to be perfect, so we can never normalize the blood pressure. And there's always going to be flares, and in some patients, no matter what we try, it just doesn't work. But I'd say most patients do feel a lot better once they have this treated. So I'll stop there, and I think should have plenty of time for questions.
Okay, great. Okay, there we go. So I'm back on. All right, thank you so much for that. That was wonderful information. And we do have a lot of questions here. So I'll start with our first one. So we have a question about Lewy body disease. My husband has Lewy body. He's had OH for a while and is on fluorocortisone, but recently he will suddenly feel weak while already standing and collapse unless he can sit down or someone can help support him. Is this the same thing? Is this the same?
Yes, probably, but it could also be a fainting reflex. So, fainting reflex can happen to anyone. It's not considered a disease. It happens to young, very healthy people. But it's obviously a problem if, you're fainting frequently. So, orthostatic hypotension, the blood pressure drops kind of gradually, and most people don't faint because of it. But what this vasovagal syncope, which is the medical term for the fainting reflex, the blood pressure can drop really quickly, and there's really not a great way to treat that. It's kind of all the same treatments that I discussed for OH. The only way to really tell like what's causing what is to have a tilt table test done, but I would say, when you sit them down, just check the blood pressure, because usually the pressure will drop and it will stay low. And either way, even if you can't tell if it's fainting or gradual blood pressure drop from OH, if the pressure is low, you can treat that. So answer is it's hard to say, but either way, I would put a blood pressure cuff on if you get that on after you sit them down, check the pressure, and just start keeping a diary of what the pressure is.
Okay. Since we're kind of on this subject, you mentioned mitogen before exercise. Do you advise taking a short-acting medication before eating or sitting on the toilet? Depending on your activity, what you're going to do, would you recommend that?
Eating, yes. You don't usually do it for, you know, mostly bowel movements or straining is when people can faint, but we don't usually do it for that, because you have to anticipate it a little bit, because you want to take it at least 30 minutes before, and so sometimes that can be difficult when you're
Mhm.
timing your restroom, breaks. But exercise and eating, yes. So some people that get really lightheaded after they eat, you can take mitogen about 30 minutes before eating, and that can help.
Okay. Are periodic medication adjustments for OH needed as a disease progressive? Do you eventually run out of medication options?
Yeah, it can happen. It can happen. Yes. So, um, yeah, I mean, as the disease progresses, this can and often does get worse. So we'll need to make adjustments, go up on doses. Also, sometimes I think that the receptors get sensitive to the medication. If you're on maximum doses and it's not working, then you might want to think about taking like a break from the medication for a week or so, and then restarting it sort of to reset the receptors.
Okay. How do these medications affect OH? Emmetadine, Sinemet, and modafinil. I'm sure I didn't pronounce that right, but
Yeah. Amantadine, I don't think does much. Sinemet lowers blood pressure. So some people it lowers it a lot, some people not so much. But if you're on Sinemet and you also take something like midodrine, I take them together. So the midodrine can counteract that a little bit. And if you're on Sinemet, you might want to check your blood pressure 30 minutes after you take it, laying and standing, see how much it drops. Um, Modafinil increases blood pressure a little bit. So that's kind of similar to the atomoxetine because it is a stimulant. So it'll increase it slightly, which can be a good thing.
okay. Do you think OH is more severe in MSA than in Parkinson's or Lewy body dementia?
Yes. Yes.
Yeah. Okay. And can you talk about, I'm not 100% sure what she means by this, but C/L medication dosing times. Find eating more carbohydrates for breakfast causes OH episodes sometimes, and taking, levodopa. Yeah, okay. Carbidopa, levodopa before breakfast causes more OH in the AM. Does that make sense?
Yeah. So the question is about timing of when to take
Right.
dopa and eat it
Yeah,
with
dosing
meals.
times. Yeah, was the question for
Yeah.
carbidopa, levodopa.
Well, I mean, I can just tell you the kinetics of the drug, and then you can kind of, adjust your dosing based on that. I mean, the something like midodrine and droxidopa are gonna peak
Yes.
within half an hour, and they're gonna stay in your body for 3 hours. So if you want to have the drug at their peak, take it half an hour before you know, eat or take your levodopa. I mean, it's not feasible for a lot of patients because they take so many medications, but if you really want to have maximum effect of the drug, you take about half an hour before you do whatever it is that drops your pressure. Some people that's just getting out of bed in the morning. So we'll tell patients with severe OH to have the pill on the bedstand with the glass of water and take it, 15 minutes before they even get out of bed and go to the bathroom, drink the water, and then start the day.
Yeah, that's what we used to do. So do you think that like high carbohydrate meals affect blood pressure?
Yeah, so I should have mentioned that. Those are the worst. Yeah, high simple carb meals are the ones that will cause more of that blood flow to your stomach and will drop your pressure. So you want to limit simple carbohydrates. Eat more complex carbs, have more protein with your meal. Avoid just large portions of simple carbohydrates.
Um, so my family member passes out often. When should I go to the ER, if ever?
Yeah, maybe only the first time, and then
Then
not
after that, you
not
don't
the next
bother.
time because yeah, I mean, the ER is not going to really do anything for syncope other than making sure it wasn't a stroke or a heart attack. And so, um, the point is like fainting's not dangerous unless if you hit your head or we don't know if you hit your head, then you should go. But if there wasn't any head injury or any other injury, um, there's not really a reason to go to the emergency department, especially if you know that you have low blood pressure or orthostatic hypotension, just because we know that that's really common with that condition.
Okay, and they don't always know that in the ER, that's for sure. So are primary care physicians typically familiar with these specific medications for orthostatic hypotension, or would a neurologist be the doctor to prescribe these?
Yeah, some primary care, if they're adventurous, will be okay with midodrine. Um, Most are not, though. Usually it's cardiologists or movement disorder neurologists. I mean, even general neurologists don't prescribe these a lot.
Mhm.
So it's most patients actually end up getting them prescribed by a cardiologist, like in community practice, and then when they go to a specialist like a movement disorder neurologist, then they might take over. And then if they're lucky enough to have an autonomic center around, then of course the autonomic doctor would prescribe them.
Okay. And then next one, my systolic blood pressure will drop 40 or more points when standing. I also have a swallowing problem and have a lot of trouble drinking, even with thickeners. Any suggestions?
So I'm assuming, can't swallow pills.
The water, maybe the water solution.
Yeah, yeah. If you can't swallow pills, then the options are limited. I have prescribed IV saline boluses for some patients, couple with MSA. It can work, again, that's something you have to convince your doctor to do because they're really hesitant to do that, but it's safe and it can be effective just to get like a liter of saline once a week kind of scheduled if you really can't drink the water, you can't take pills. But, otherwise it's just those counter maneuvers that I talked to you about.
Mhm. In your experience, how often does OH appear before motor symptoms in Parkinson's or MSA? And what are the earlier red flags to look for?
Yeah, I think there's different phenotypes, like different presentations. Um, we definitely see a lot of patients that just have neurogenic orthostatic hypotension. Often there's other autonomic symptoms associated with that, like constipation, some urinary issues, erectile dysfunction in men. Um, I'd say red flags, meaning red flags of a neurodegenerative disorder would be loss of smell and acting out your dreams, RBD behaviors. If you have that plus orthostatic hypotension, it's probably an early form of one of these conditions, um, or probably trouble speaking or swallowing. Um, but there are a lot of patients that develop the motor symptoms first and then they develop the autonomic later. I think in MSA, the autonomic tends to happen pretty early on. In Parkinson's, it comes out later. So Parkinson's, it's usually um, maybe acting out dreams, constipation, and then motor symptoms, and then the orthostatic hypotension. But in MSA, it all kind of, I think, hits at once.
Mhm.
Uh, and then there's another, like maybe a third form where people will have just the orthostatic hypotension for years to decades. And we know from the studies that 70% of those people will never develop anything else. They'll be fine. But then 30% can go on to develop Parkinson's disease, MSA, or Lewy body dementia. And that's over a time period of 10 to 15 years.
Okay. Is sweat response one of those early flags too? Like lack of sweating?
Yeah, it is. Yeah, it's not specific to MSA, but say both in MSA and Parkinson's disease, loss of sweating can be a flag. Yeah.
Okay. So what are the brain circuits involved in orthostatic hypotension?
Okay. Well, if you want to nerd out on it, so try to explain it. It's so the baroreflex is the main reflex, and so there are sensors in the carotid artery and in the aortic arch that sense pressure changes in the vessel. So when the pressure drops, like when the blood pressure drops when we stand, that will initiate a feedback loop where those sensors will send a signal to the brain, to the brainstem, to the lateral medulla in the brainstem, and then that'll stimulate a kind of a reflex that goes back down through the brainstem, the spinal cord, and into the peripheral nerves, the autonomic nerves, and it will stimulate release of the norepinephrine, so cause vasoconstriction, and there'll also be a signal to the heart to increase the heart rate. So the end result is that blood pressure and heart rate both go up. In NOH, the baroreceptors aren't working, so the signaling doesn't get to the brain, it doesn't get back down, and it doesn't get to the heart. Um, so all the receptors are in the carotid, mostly in the carotid in the neck. So you can also see this condition, which I didn't mention, in patients who've had like carotid surgery, who've had neck surgery, or if they've had radiation to the neck for like head and neck cancer.
Okay. I had OH years before I was diagnosed with Parkinson's disease. I worked a lot in a squatted position for long periods and would go to get up and almost pass out. I complained to my doctor and never He never tested my BP laying down or standing up. It was my chiropractor who finally did my blood pressure laying standing and diagnosed me with OH. I was diagnosed a year later with PD. Do you think I could have had PD years before being diagnosed?
We definitely probably had the disease process going on. The diagnosis of Parkinson's disease, it's still based on the neurological exam, so that would really depend on the motor symptoms. Even though we can do tests that show that there is this like Parkinson's protein in the body, um, the criteria still we can't diagnose Parkinson's disease until there are motor symptoms, and that's a little bit subjective, but that's just based on a neurological exam, with movements, gait, things like that. But I think it brings an important point that, a drop in blood pressure without any other obvious cause is not normal. And that is definitely associated with, early development of these Parkinson's conditions. So that's something that, we're trying to educate more doctors about, that if that's diagnosed, that, they should look a little harder for some of the other neurodegenerative symptoms.
Okay, thank you. What are your thoughts on skin biopsy markers? Is this helpful in predicting progression to a neurodegenerative cause?
So right now, no. I mean, the data um, that we have tells us it's helpful to distinguish non-neurodegenerative causes of these conditions, but it's not helpful to sort of inform prognosis. Um, if you have neurogenic orthostatic hypotension and you have RBD or you have constipation, um, we don't need to do a skin biopsy to confirm it's synuclein. It is synuclein. You can assume that. I mean, that being said, patients still, some of them still want to know, and it's an easy test to do. Um, but we know that say in the NOH population that have other autonomic symptoms, that skin biopsy is positive in over 95%. In Parkinson's, it's the same, over 95%. Same with Lewy body dementia. In MSA, it's present in probably over 80%. So it's something that I would only do if the diagnosis is not clear, which is usually more common in MSA. It's a lot clearer in Parkinson's disease, but MSA is tricky, and it's due to this, like, the implications of that diagnosis. We really want to get it right. So, much more likely to offer the skin biopsy in someone with potential MSA than, if they have clear Parkinson's disease.
Okay. Is it common for someone with Lewy body and NOH to also experience episodes of hypertension from time to time, not just when supine?
Yeah. Yeah, that can happen. Yeah. I mean, because those baroreceptors are just not working. So sometimes you'll get labile blood pressure, and it's not just related to being supine. So, I didn't mention this in treatment, but in these cases, sometimes we'll actually give antihypertensives as well as the midodrine-like drugs. Um, it can be hard, it can be tricky and potentially dangerous to do that depending on how much the blood pressure drops, but it can be good to give that at night, like before bed, to give a short-acting medication, to drop the blood pressure right before bedtime.
You said OH is more severe in MSA. What exactly does that mean?
The drops are more severe, it drops lower, and I think it's also more refractory to the medication. It's just harder to treat because I don't think that the brain responds as well in MSA as it does in Parkinson's to these drugs.
Okay. You didn't mention anything about a tilting wheelchair that had a tilt feature on it as far as non-pharmacological help for people with the MSA or people that have OH. Do you think that's helpful for patients?
I mean, only if you pass out when you're sitting. I didn't mention that because most people don't faint if they're sitting. I mean, that can happen in really severe cases, in which case, sure, that would be useful. But if you don't pass out or have like pretty severe symptoms when you're sitting, you shouldn't need that.
Um, my husband has CBD, not MSA or PD. When he lies down, he's clear-headed. When he sits up, he's mentally confused. Could this be related to blood pressure?
Could be, CBD, to my knowledge, does not have a strong association with OH, but it can happen. So, like I said, if there's any of those symptoms that are orthostatic, it's very simple to do orthostatic blood pressures and show that to your doctor. We have on our website, if you look up if you just Google Stanford orthostatic blood pressure log, on the autonomic website, there's a Word document that's orthostatic log you can download. So I'll tell a lot of patients to do that and just check your pressures for a week, and then just show them to your doctor, and that'll really answer the question.
Okay. And then here's our last question. If someone has an MSA diagnosis, do they always have OH?
Doesn't go away. It doesn't go away, but people can get more or less symptomatic over time. So um, I think the brain adapts, people adapt to it. There's also probably changes in the brain that can happen where the symptoms can get better over time, but the blood pressure doesn't. The disease doesn't just go away, unfortunately.
Yeah, for sure. So anyway,
Yes.
so I think that's it. We're going to wrap up here. We thank you so much, Dr. Miglis. That was a great presentation, and thank you for all those great answers to the questions. Um, and thanks you everybody for who attended today. And once again, we will have this information on the BSN YouTube page and on the BSN website for you to see in about a week. Hopefully, we'll have that up. So thanks again, and we'll see you soon.
Thank you. Thank you, Candy. Thank you, Robin.
All
Thank you,
right.
everyone. Bye.
Bye-bye.